Today is March 20th, 2026, and we are witnessing some of the most bizarre and brilliant breakthroughs in medical history. Imagine a world where your daily coffee could lower your risk of death, or a common skin infection vaccine could save your heart. Overview: we're diving into shingles for heart health, a massive shift in the weight loss drug market, and why closing your eyes to hear better is a scientific no-go. Segment 1: the heart-saving shingles vaccine. The story: a groundbreaking study released today reveals that a common shingles vaccine might double as a powerful heart protector. The data: in high-risk individuals, the vaccine was found to cut major cardiac events by 46% and deaths by a staggering 66% within just 1 year. The why: scientists believe that by preventing the shingles virus, they are also stopping the inflammatory triggers that lead to blood clots and heart attacks. Segment 2: Ozempic alternatives and the weight loss rebound, 3 to 5 o'clock. The news: huge news for the skinny shot era. Semaglutide, the active ingredient in Ozempic, has officially gone off patent in India, leading to a wave of low-cost generics. The warning: doctors are issuing urgent warnings against aesthetic misuse by non-obese individuals chasing social media trends. The rebound myth: interestingly, a massive study of 8,000 patients found that stopping these drugs might not trigger the dramatic weight rebound many feared, provided patients managed the transition properly. Segment 3: targeted viral cancer therapy. The breakthrough: researchers have developed a modified virus therapy that acts as a homing beacon for the immune system to find and kill glioblastoma, one of the deadliest brain cancers. How it works: a single injection supercharges immune cells, allowing them to invade the tumor and destroy it from the inside out. Segment 4: diet, longevity, and hidden dangers. The good news: new research suggests that consuming fermented dairy, yogurt/cheese, and chocolate is associated with a 6% reduction in all-cause mortality, thanks to anti-inflammatory cocoa polyphenol. The bad news: ultra-processed foods, chips, sugary drinks, are now linked to a 67% higher risk of heart attack and stroke for those consuming roughly 9 servings per day. The surprise: contrary to popular belief, a massive review found no evidence that medicinal cannabis effectively treats anxiety, depression, or PTSD, and may actually increase the risk of psychosis. Segment 5: quickfire newsroom. FDA alert: the FDA just approved Icotide, icotrokinra, the first ever targeted oral peptide for plaque psoriasis, potentially ending the need for daily injections for many. Parkinson's link: sustained exposure to the pesticide chlorpyrifos has been found to more than double the risk of developing Parkinson's disease. Medical negligence: in a landmark ruling, the National Consumer Dispute Redressal Commission fined a hospital 10 lakh rupees for performing an ENT surgery without a mandatory CT scan, leading to brain injuries. Semaglutide, practical prescribing note for physicians. 1. White heavy checkmark indications, evidence-based. Asterisk type 2 diabetes mellitus, T2DM. Inadequate control on metformin plus or minus other OADs. Asterisk ASCVD/high CV risk, CV benefit proven, sustain 6. Asterisk obesity/overweight. BMI greater than or equal to 30 kg per square meter or greater than or equal to 27 kg per square meter plus comorbidity. Particularly useful in insulin resistance. NAFLD. COS. Cardiorenal benefit. Reduces MACE, slows CKD progression, flow trial emerging data. 2. Dosage and titration, key to tolerability. Subcutaneous, weekly. Start, 0.25 mg once weekly, 4 weeks. Then, 0.5 mg weekly. If needed. 1 mg 2.0 mg, diabetes. Up to 2.4 mg, obesity, Wegovy equivalent. Oral semaglutide. Start, 3 mg daily, 30 days. Then, 7 mg 14 mg. Golden rule: start low, go slow to avoid GI intolerance. 3. Mechanism, for clinical insight. GLP-1 receptor agonist. Appetite, central satiety. Gastric emptying. Insulin, glucose dependent. Glucagon. 4. Common side effects. Very common, dose-dependent. Nausea, most frequent. Vomiting. Early satiety. Constipation/diarrhea. Important clinical concerns. Pancreatitis, rare but serious. Gallstones/cholecystitis. Dehydration AKI risk, especially elderly. Worsening diabetic retinopathy, rapid HbA1c drop. 5. Special situations and high-risk groups. Red circle immunocompromised patients. No direct immunosuppression, but risk of malnutrition due to appetite suppression. Monitor weight loss speed. Protein intake. Use cautiously in cancer, cachexia. Chronic infections, TB, HIV. Red circle renal disease. Safe in CKD, no dose adjustment. But watch for AKI due to vomiting/dehydration. Red circle hepatic disease. Generally safe. Useful in NAFLD/NASH. Red circle elderly/frail. Start ultra low and slow. Avoid sarcopenia, ensure protein intake. Red circle thyroid caution. Avoid in medullary thyroid carcinoma, MTC. MEN2 syndrome. 6. Drug interactions, very important in practice. Due to delayed gastric emptying. Absorption of oral drugs. Levothyroxine, give half an hour before semaglutide. Antibiotics. Oral contraceptives. Advice, give critical drugs separately. Hypoglycemia risk, when combined with sulfonylureas. Insulin. Reduced dose of SU/insulin. Caution with diuretics, dehydration risk. NSAIDs AKI risk, if volume depleted. 7. Monitoring protocol. Baseline. HbA1c. Weight, BMI. KFT. LFT. Lipid profile. Follow up. Weight, monthly. HbA1c, 3 months. Renal function, if GI symptoms. Watch. Persistent vomiting. Abdominal pain, pancreatitis. 8. When to stop/hold. Suspected pancreatitis. Severe GI intolerance. Rapid unexplained weight loss. Severe dehydration. Pre-surgery, stop 1 week prior. 9. Practical pearls, Indian context. High misuse risk in cosmetic weight loss clinics. Counsel patients. This is not a lifestyle shortcut. Needs diet plus exercise. Avoid BMI less than 25 cosmetic use. Watch. Lean diabetics, common in India, risk of excessive weight loss. 10. Clinical bottom line. Heavy checkmark, excellent drug for diabetes plus obesity plus CV risk. Risk lies in overuse, rapid titration, and poor monitoring. Right patient plus right dose plus right follow-up equals best outcomes. Key evidence for academic use. Sustained trials, T2DM efficacy and CV outcomes. Step trials, obesity. ADA 2024 guidelines. Flow trial, renal outcomes. Semaglutide, know before you log in. 1. Expected weight loss, how much, how fast, in whom. Small blue diamond, average expectations, step trials plus real world. 0 to 4 weeks, minimal, dose escalation phase. 3 months, 4 to 6% body weight, square root 5%. 6 months, 8 to 12%, square root 10%. 12 months, 12 to 15%, can reach 18 to 20% in responders. Small blue diamond, who responds best. Heavy checkmark obese, BMI greater than 30. Heavy checkmark high insulin resistance, central obesity, NAFLD. Heavy checkmark good adherence, diet plus protein intake. Heavy checkmark no severe GI intolerance. Small blue diamond who responds poorly. Lean T2DM, common in India. Long-standing diabetes on insulin. Emotional eaters / binge eating. Sedentary lifestyle. Clinical pearl. Less than 5% weight loss at 3 months, on greater than or equal to 1 mg dose, reassess adherence / escalate / rethink therapy. 2. Avoid combination with DPP-4 inhibitors. Vildagliptin, sitagliptin, linagliptin avoid. Crossmark why? Same incretin pathway, no added benefit. Cost without efficacy. Potential GI side effects. *** rule ***. Stop DPP-4 inhibitor before starting semaglutide. 3. Switching, tirzepatide semaglutide. Tirzepatide to semaglutide. Small blue diamond when to switch. Cost issues. Intolerance, nausea, diarrhea. Availability. Small blue diamond how to switch, practical approach. Heavy checkmark no washout required. Heavy checkmark start 1 week after last tirzepatide dose. Suggested conversion * semaglutide is 10x more potent than tirzepatide, may not be equally effective. Tirzepatide 5 mg, semaglutide 0.25 to 0.5 mg. Tirzepatide 10 mg, semaglutide 0.5 to 1 mg. Tirzepatide greater than or equal to 12.5 to 15 mg, semaglutide 1 mg. Then titrate slowly. Important. Expect slightly less weight loss versus tirzepatide. GI symptoms may still occur, go slow. For side effects monitoring, practical OPD protocol. Eye monitoring, retinopathy risk. Small blue diamond why? Rapid HbA1c fall, retinopathy worsening. Small blue diamond who is high risk. Pre-existing diabetic retinopathy. HbA1c greater than 9%. Rapid glucose drop. Small blue diamond what to do to prevent eye issues? Heavy checkmark baseline fundus exam. Heavy checkmark repeat at 3 to 6 months. Red flags. Blurring of vision. Floaters. If present, refer ophthalmology plus slow glycemic reduction. B. Weight monitoring. Heavy checkmark weekly, patient self-monitoring. Heavy checkmark monthly, clinic. Concern if 1.5 to 2 kg / week loss. Sarcopenia, weakness. Ensure. Protein intake. Resistance exercise. C. Sugar monitoring. Small blue diamond frequency. SMBG initially, 2 to 3 times / week. HbA1c, every 3 months. Watch for hypoglycemia, if on insulin / SU. Excessive drop, greater than 2% HbA1c in 3 months. Adjust. Reduce SU / insulin dose early. D. Dehydration and renal monitoring. Especially if vomiting. Heavy checkmark check creatinine if persistent vomiting. Elderly. 5. When side effects occur, what to do? Small blue diamond GI intolerance, most common. Hold dose escalation. Step back to previous dose. Small frequent meals. Small blue diamond persistent vomiting. Stop drug temporarily. Hydrate. Check renal function. Small blue diamond suspected pancreatitis. Severe epigastric pain, stop immediately. Check amylase / lipase. Final clinical takeaways. Heavy checkmark, expect 10 to 15% weight loss over 1 year in ideal patients. Heavy checkmark, avoid DPP-4 inhibitors, Vilda/Sita/Lena. Heavy checkmark, switch from tirzepatide without washout, but start lower dose. Heavy checkmark, monitor eye, retinopathy. Weight, avoid sarcopenia. Sugar, avoid rapid drop. Most important to know about semaglutide, which no pharma house tells. Muscle loss, sarcopenia, with semaglutide, clinical caution. Why it happens. Rapid weight loss equals loss of both fat plus lean mass. Appetite suppression, reduced protein intake. Sedentary patients' muscle catabolism. Studies show 25 or 40% of weight loss may be lean mass if not protected. Who is at high risk? Elderly patients. Lean diabetics, Indian phenotype. Chronic illness, CKD, cancer, TB. Low baseline protein intake. Sedentary lifestyle. Prevention strategy, must prescribe along with drug. Exercise, non-negotiable. Resistance training, most important. 3 to 4 times/week. Even simple. Chair squats. Wall push-ups. Light weights. Aerobic, walking 30 minutes per day. Without resistance exercise, muscle loss accelerates. Protein intake. Target, 1.0 to 1.2 g/kg/day. Up to 1.5 g/kg in obese with weight loss. Asterisk, practical Indian advice asterisk. Paneer/curd/dal/chana. Eggs, if non-veg. Protein supplements if intake poor. Divide protein across meals, important with low appetite. Calcium and vitamin D. Calcium, 1000 to 1200 mg/day. Vitamin D, 800 to 2000 IU/day. Why? Prevent bone loss plus support muscle function. Weight loss, bone density decline risk. 4. Weight loss target, controlled, not aggressive. Ideal, 0.5 to 1 kg/week. Avoid crash weight loss. Excess dose escalation. Monitoring for sarcopenia. Clinical signs. Asterisk, weakness. Asterisk, difficulty rising from chair. Asterisk, fatigue. Simple OPD tools. Hand grip strength, if available. Mid-arm circumference. Gait speed. Red flags, act immediately. Rapid weight loss, greater than 2 kilograms per week. Visible muscle wasting. Fatigue, falls. Action. Reduce dose. Increase protein. Intensify resistance training. Clinical bottom line. Weight loss is not equal to healthy loss unless muscle is preserved. Heavy checkmark, always co-prescribe. Exercise. Protein. Calcium plus vitamin D. Exclamation mark, otherwise. Sarcopenia. Frailty. Worse long-term outcomes. Today semaglutide becomes off patent in India. Credits, Dr. Satish Gupta. From being a yogi in the Himalayas to becoming a nuclear physicist. Story of nuclear scientist Dr. Professor Swami Jnanananda. Early life and spiritual journey. Birth. Born as Bhupati Raju Lakshmi Narsingha Raju on December 5, 1896, in Goraganamudi, West Godavari district, Andhra Pradesh, India. Family background. His father, Rama Raju, was a wealthy landlord and Vedic scholar. Growing up in a house filled with ancient scriptures, Jnanananda developed a deep interest in spirituality and mathematics from a young age. Renunciation. At the age of 21, inspired by Buddha, he left home for the Himalayas to pursue spiritual practices. He spent approximately 10 years there, practicing yoga and studying Vedic literature. Sannyasa. He was initiated into sannyasa, monkhood, by Swami Jnanananda, who gave him the name Swami Jnanananda. Philosophy. During his spiritual period, he authored the Purna Sutras, or Purna Sastras, a major work on Vedic philosophy. His major philosophical works. 1. Purna Sutras, available in Sanskrit, Telugu, Hindi, and German. 2. The Philosophy of Yoga, lectures on Raja Yoga. 3. The Essence of Indian Philosophy. 4. Science and Religion. 5. Transcendence, a study of the state of samadhi. Authored nuclear physics textbooks. The Elements of Nuclear Physics, 1962, a comprehensive 580-page textbook used by generations of Indian postgraduate students. Nuclear Models and Beta Decay, 1975, posthumous, a deep dive into the theoretical structures of the atomic nucleus. Academic and scientific achievements. Initially traveling to Europe in 1927 to print his philosophical books, Jnanananda developed an interest in physics that led to a world-class academic career. Dresden University, Germany. In 1927, Jnanananda traveled to Germany to publish his philosophical writings. While there, he attended a lecture by Professor Dember on Einstein's theory of relativity. Finding his mathematical background insufficient to grasp the complexities, he decided to master the subject. He remarkably completed a German undergraduate course in physics and mathematics in just 2 years, by 1929, financing his studies by giving over 150 lectures on yoga across Europe. Charles University, Prague. Conducted research on high-tension and X-ray physics under Professor Dulcek. He was awarded a Doctor of Science http://d.sc in 1936 for developing precise methods in X-ray spectroscopy. University of Liverpool, UK. During World War II, he worked under Sir James Chadwick, the discoverer of the neutron. He earned a Ph.D., 1943, for his research on beta ray spectroscopy and the development of the thick magnetic lens beta ray spectrometer. Key details of his contribution. Thesis in Design. In 1943, he submitted his Ph.D. thesis at the University of Liverpool titled Thick Magnetic Electron Lens Beta Ray Spectrometer, Its Theory, Construction and Its Application for the Measurement of Energy Spectra. Innovation. Unlike thin lens spectrometers that use a narrow coil, Jnanananda's design utilized a thick lens, a more extended magnetic field. This provided a much greater focusing efficiency and allowed for the investigation of high-energy radiations that previous instruments struggled to capture. Performance. His spectrometer was notable for its ability to focus high-energy electrons, up to 15 MeV in theoretical design, with tests confirmed up to 3.2 MeV, which was quite significant for nuclear physics research at the time. University of Michigan, USA. Continued research on radioactive isotopes and completed his book High Vacuum, Principles, Production, and Measurement, 1947. University of Michigan, Ann Arbor, research on radioactive isotopes at Michigan. Dr. Jnanananda utilized the university's advanced cyclotron and research facilities to conduct extensive investigations into the energy levels of various radioactive isotopes. His work provided precise data on the decay schemes and energy spectra of uranium X1, thorium-234, gold-198, antimony-124, tantalum-182, tungsten-185, and iridium-192. Publication of High Vacuum, Theory, Analysis, and Measurement, 1947. While in the United States, he finalized and published his influential technical book, High Vacuum, Theory, Analysis, and Measurement, 1947. This book became a standard reference for physicists and engineers working on vacuum technology, which is essential for the operation of particle accelerators and spectrometers. Establishment of Indian nuclear research. Upon his return to India in 1947, Dr. Professor Swami Jnanananda was invited by the Government of India to join the newly established National Physical Laboratory, NPL, in New Delhi. Role and contributions at NPL Delhi, 1948 to 1954. Initial appointment. He joined as a senior scientific officer in 1947-48. Promotion. Due to his expertise in high vacuum technology and nuclear instrumentation, he was promoted to assistant director and head of the laboratory/division in 1950. Infrastructure building. He was instrumental in drafting the comprehensive development plans for the NPL. Specifically, he focused on establishing nuclear measurement facilities and vacuum standards, drawing directly from his research at the University of Michigan and the University of Liverpool. Technical standards. His book, High Vacuum, which he finished in the USA, served as a foundational guide for the laboratory's experimental setups during this period. Contributions to Andhra University. Transition to Andhra University in 1954, while still at NPL, he met with a serious car accident near Bhimavaram. During his recovery, he was approached by the Vice-Chancellor of Andhra University, who invited him to establish a dedicated nuclear research department. Academic pioneer. He established a separate department of nuclear physics on July 1, 1956, one of the first of its kind in India. Infrastructure development. He designed and oversaw the construction of a dedicated building for the department, completed in 1958, and equipped it with state-of-the-art instrumentation. The Swami Jnanananda laboratories. These laboratories at Andhra University became a hub for nuclear research, specializing in beta-ray and gamma-ray spectroscopy. He guided scores of scholars for their http://d.sc and PhD degrees. His students went on to lead research at the Babha Atomic Research Center, BRC, and the Tata Institute of Fundamental Research, TIFR, effectively seeding the Indian nuclear program with trained experts. Children with worse oral health. Children with worse oral health were more likely to experience heart attack, stroke, or coronary artery disease as adults, according to a new study based on data from multiple national health databases in Denmark. Medscape. Loneliness and poor heart health. The more lonely you've been over your life, the more likely you are to have conditions that affect your heart health, obesity, high blood pressure, and bad cholesterol levels, for example. And women who are lonely may be more likely to get coronary heart disease. Why? There could be many reasons, like if you smoke, get depressed, or don't work out when you're lonely. WebMD. How exercise improves your mental health. Some benefits of exercise on your mental health can even happen right after you work out. Makes you feel happier. Exercise helps block negative thoughts and distracts you from daily worries. Your body releases chemicals, such as serotonin and endorphins, that trigger a happy feeling. Exercising with other people can boost that effect even more. Improves learning, thinking, and judgment capabilities as you age. When you exercise, your body releases proteins and other chemicals that change the brain's function and structure. It also makes the brain grow new cells that help prevent age-related mental decline. Helps relieve symptoms of depression and anxiety. Exercise acts in a similar way to antidepressant medications for treating mild to moderate depression, just without the side effects. Exercising improves brain function, lowers inflammation, and promotes the growth of nerve cells, all which can help your mood. Through the release of endorphins, physical activity also helps relieve tension and stress tied to anxiety. Being mindful of what your body is doing and how it feels as you exercise can also help interrupt the flow of negative thoughts and worries. Helps manage ADHD. Exercise is one of the best ways to take charge of the symptoms of attention deficit hyperactivity disorder, or ADHD. It helps improve motivation, mood, memory, and concentration by immediately boosting hormones that support focus and attention. WebMD. Outro: Why you should open your eyes. The takeaway: science just debunked the close your eyes to hear better myth. Research shows visuals actually help you process faint sounds in noisy rooms. Call to action: which of these breakthroughs surprised you the most? Let me know in the comments, and don't forget to subscribe for your daily dose of medical futurecasting.
Disclaimer: the information must be verified before use. The creator, publisher, and YouTube will not be liable for any negative consequences.